Do you have any families with children here registered who are under our care? Yeah, nice. Nice to see you all here. So, I mean, I think you've been through all of this morning, that these are rare disorders, mostly dominant. And the main symptoms, like in adults, are stiffness and weakness. It's just sometimes children may struggle to articulate what's happening to them, particularly in early years. And that basically leads to the challenge for diagnosis. So over the last decades, different genes, different mutations have been identified. They all have diverse presentations. But I think with children, the particular challenge is them being rare. Each child neurologist or pediatrician will not come across many children who have these symptoms, and they may struggle to diagnose these children because the symptoms are fluctuating quite often. The teachers struggle to recognize how the child can be normal at one time and can have so much difficulty at other times. Being outside in PE can be a challenge. So it's just the variation which baffles people sometimes. And therefore, they often get diagnosed late. So we looked at the children in our center, which is Great Ormond Street Hospital next door, with 38 affected children with channel disorders. And this was the spectrum. So the top of the list was paramyotonia congenita, sodium channel mutations, nearly half. And then we had myotonia congenita, which is a chloride channel mutations, and smaller numbers for periodic paralysis and Anderson-Tawil syndrome. And when we looked at the detail of the different presentations, most of the time it was leg myotonia for the chloride channel, but for the sodium channel, it may be more eyelid myotonia or squint or double vision or hand myotonia, exacerbated by cold weather. Whereas in chloride channel, the children, often the teenage children could say that, oh, when I need to get off the bus or the car, I cannot stand up, and they can articulate, whereas the younger children would just frequently fall over. And nobody could understand why they are falling over because they cannot articulate what's actually happening to them. And therefore, I think history taking for us as clinicians, it's really important to try and understand the circumstances under which the frequent falls take place. So we go a little bit more into detail. And even when the adult studies have been published, if you look at the age of onset, it's the pediatric age group when they start noticing the symptoms. It's not really, it's a lifelong condition. And when we looked at the detail of what the symptoms could be, so there are various ones which are described, but fisted hands, like in babies or infants, which are clenched in the cold weather. When they sneeze or they cry, the eyelids look like stuck. So parents know, particularly if they are affected, within the first couple of years, they will know whether the child has it or not. And I'm sure all of you will have noticed that. The challenge is when you don't have an affected family member. That's where the delay happens, because if you all will recognize the symptoms if you're affected. And sometimes we end up diagnosing the child and the parent at the same time, because the child presents, and then we go back looking at the family history and ask the parent, have you ever noticed that you have stiffness or you have problems? And then they also get the diagnosis. Little infants may sometimes have laryngeal or breathing related stridor causing problems with swallowing or feeding, or just noisy breathing, and sometimes it can be quite significant and severe. Some children may report double vision, while others may have sort of night cramps, an abnormal stiff gait, which then gets better as they do more and more activity as they warm up, and then falls and limited exercise tolerance. So these are the various age groups. So you can see from 0 to 18, there's quite a spectrum, and you can have children presenting at any age. And this is a slide looking at the time to diagnosis, and you can see on the right-hand side that some people have taken up to 13 years to get a diagnosis, even though they've presented 13 years ago. And I put down the family history. In 24 we had family history, so that made it easy. But in the remaining 16, it was challenging to get to the diagnosis. Anything between, if you get it straight away at 6 months, the diagnosis. But if you don't, then you can see that there is a problem if it's not immediately recognized. And when we examine these children, the symptoms are more or less same as adults. They may have muscle hypertrophy, but that takes time to build up. So it's more in the teenage age group rather than the younger children. We see the grip myotonia, which you all may know what it is, or the eyelid myotonia, which we assess in clinic. They may demonstrate the warm-up phenomena. So sometimes we ask the little, young children to run in the corridors to see how the walking changes when they start and when they've done 5 to 6 rounds. And some may have transient weakness. And then moving on to periodic paralysis, again, this is, just like adults, this is equally challenging for children. We had 7 children. Most of them were because of family history. But I had a couple with a calcium channel mutation where they were, misdiagnosed as being functional in children. Functional meaning like sort of not true weakness, but psychological in some ways. And that obviously causes a lot of frustration for families. But they could be because of hyper-PP or hypo-PP. And the most common we have is the calcium channel mutation, but also sodium channel mutation equally. And these are slightly difficult to treat. Calcium channel less so, but sodium channel and Anderson-Tawil, we find it quite challenging to treat. We refer them to the cardiology team for the Anderson-Tawil syndromes, but the periodic weakness often doesn't respond, and we have to try various different medications, which is quite disruptive, particularly for those in education, because they wake up in the morning, they are weak, they cannot get to school, and by the time they get strong, half the day is already gone, and therefore that causes a big problem for them in terms of school attendance and staying in education. And again, the meal, the carbohydrates are difficult to control for the children, because most of them prefer to eat sort of pizza, pasta type of meals, so that often triggers parties, will trigger the attacks in the morning. And this is a particular group of conditions where we have newborns born to adults with paramyotonia congenita, mothers where there may be a laryngospasm, but we always try and counsel the families to say that, if you're pregnant, just make sure, I think Deepa might have already mentioned that earlier, that be aware that this could be a problem, and there's a very quick treatment which can be offered with carbamazepine. So it's really important to recognize. And then the treatment in children is similar to adults. So for the neonatal presentations, obviously we need to make sure we support the breathing, we support the feeding, we recognize and start treatment early. But often our nurse specialist, Shan, who couldn't be here today, but she often has to liaise with the school to provide them, information sheets about the conditions so the teachers can understand this a bit better. She also does some letters for support explaining what things can be put in place, for example, PE indoors, or letting them being wrapped up warm. Support with writing for the hand myotonia or the grip myotonia, particularly in secondary school when they have to do long essays. So we try and do as much liaison and support as possible to allow inclusion and so they don't feel uncomfortable being at school. And then with regards to pharmacological treatment or medications, they're more or less the same. The challenge is more providing the evidence because it's easy to do research, all the, lovely trials and cohort studies that Venu's leading on. They are difficult to execute in children for reasons which may be, like in terms of consenting, safety of the medication in the children. So it's not easy to conduct the trials. The numbers are also small, so we don't have that many patients. And if half of them don't participate, we're reduced to even less. But we are trying. And sometimes what happens is that we get the license in adults, and then we use the medication unlicensed in children, because in order to get a license, we need to have the research. So we are stuck in a situation where we can't demonstrate it works, therefore we can't get a license, and therefore we can't get colleagues like general practitioners and pediatricians to prescribe the medication because it's not licensed. So they would not prescribe, which then means the families have to collect it from here, even if they live in Cornwall or somewhere far away. We are trying to work with the pharmacy team to see if they can be posted so that children don't go without medications. But I think lately, and it's particularly true for meglitine, lamotrigine and carbamazepine, because they're anti-epileptic medication, they already have a license in children, so they're far more easier. So the new study that Dr. Venu's published in Lancet is really welcome, because we can now then try more lamotrigine, which is licensed and much easier to prescribe. But on the whole, I think compared to adults, because children don't have underlying cardiac disease, or the problem with cholesterol and atherosclerosis in early life, the side effects with meglitine are not as much, and therefore it's much better tolerated in children. And then for the periodic paralysis, just like the adults, we use a similar plan of treatment. So treatment for the acute attacks and then preventing the attacks in future. So we tend to use sandoke or potassium for the acute attacks and then try various medications like acetazolamide or amiloride. And we work down our way through all these medications over time. We also have another presentation in children which is called as a calcium channel mutation, where they have fixed weakness right from the beginning. It's called as congenital myopathy. So the babies or the children will have weakness right from birth. They may also have feeding difficulties. And this has been reported with both calcium channel and sodium channel. It's a completely different presentation, different mutations, nothing like the periodic paralysis that we know of. So I think to summarize, the main challenges I've said along the talk are delays in diagnosis, working with the children who have periodic paralysis, for them to convince the teachers and the carers that, these are genuine and they need interventions. We don't know if these children who are undertreated over time, whether they will develop fixed weakness in the older age group, because there are no long enough studies to look at children from an early age for the next 3 decades to see what happened when they reach the 4th decade. And would that outcome be different if you give them treatment properly, whereas undertreat them? Is that really going to make a difference? I don't know the answer because there aren't that many long enough studies. And then I think the final part is prescriptions with mexilatine, knowing the efficacy and safety and licensing. But we work very closely with the Queen Square lab for children where we find mutations where we don't know, is it really the cause? We then rely on the lab here to help us by doing work in the lab in terms of functional work to prove that, yes, this is damaging. Because sometimes we find mutations which are there, they've never been reported in anybody else, and we don't know if they are just a mutation which is found because we were looking or it's actually the cause. And then we have to rely on the team in Queen Square to help us with the functional work. And therefore we work quite closely. So I think to summarize, the presentation is nearly the same in children, but it's just articulation and recognition is often difficult. Many different presentations, and I think we try and do as much education as possible for pediatricians, neurologists, trainees, to try and spread awareness about the condition. Emphasizing the importance of examining for myotonia in clinic, because it's a 20-minute appointment in a pediatric clinic. By the time you go and tell them what happened, if they don't actually look for myotonia or they don't see you standing up from the floor or running around in the corridor, they're not going to be able to pick up the myotonia. So we really emphasize that you look for the myotonia if you want to not miss the diagnosis. And consider testing for them in patients who have undiagnosed frequent falls, undiagnosed stridor, undiagnosed stiffness and hand difficulties, even if they don't have a strong index of suspicion. And this is a pediatric clinic which Deepa and I do together at Great Ormond Street Hospital. So if you have any children that you would like us to see, we're obviously very welcome. Thank you.